Well, we can go ahead and get started. I recognize it's 8 p.m. on a Sunday, but thank you all for joining us for our second lecture on reading angiograms. I recognize many of you were with us for our first lecture, so thank you for returning. I'm pretty excited about today's talk. I think the first lecture had a lot of foundational information, so today we will kind of apply those principles on never before seen angiograms, and hopefully we'll work to kind of refine or hone interpretation skills so that when you're in the cath lab, whether that's tomorrow or next month, or reading angiograms on your CCU rotation, you'll kind of be able to shine. So looking forward to getting started here. I have no disclosures. I will just share that this meeting is being recorded. We will be posting this lecture on our YouTube channel just so that everybody who couldn't make it today can still enjoy it. So this is an outline for the talk. Just wanted to kind of review what we'll be discussing today. Essentially, for the first 10, 15 minutes, it's a small didactic piece. We have this algorithm that we've developed for angiogram interpretation. I remember that when I was a general fellow, oftentimes people would cold call on me to read angiograms, and I think that having an algorithm to kind of fall back on or a framework will really kind of help you strengthen your interpretation skills for rounds or the lab. So we'll kind of introduce that algorithm today. Hopefully we don't belabor it too much, but these will be the questions and the framework that we use kind of throughout the course today. And, with time, we'll kind of stop asking those questions, but just in the beginning to kind of have a framework, we'll introduce that algorithm. We'll then kind of use it for some examples with the left coronary artery and then with the right coronary artery. And then really the remaining 45 minutes of the talk will be kind of looking at angiograms together and reading them and kind of putting our interpretation skills to the test. So we'll go ahead and get started. So this is that algorithm that I mentioned. These are kind of the 5 questions that I encourage you all to think about when you're approached with an angiogram. So that first question is, in what view is this projection? And I think that that question can be really helpful to you because it will kind of give you an idea of what are we looking at in this shot? Are we focusing on the circumflex? Are we focusing on the LED? So I think having a sense of what view you're looking at is important. I think the next question that's important is this a radial or a femoral approach? I think oftentimes knowing that can be helpful to you because it tells you, was the operator perhaps struggling with support? Were they struggling with catheter engagement? Should they have converted to femoral? And I think, when you're asked to read an angiogram, I think if you just mention that up front, I think that it really tells the observer or the person that's asking you that this person really understands the X-ray, they really understand cardiac catheterization. So I like to include that question in our algorithm. Then our third question, of course, is, can you identify the vessels? And the fourth question is, can you name the lesions? Which I know is kind of what we're all after and what, one of the main exciting parts about interventional cardiology is. And then finally, if there is one, what is the diagnosis here? So in today's talk, we'll kind of use these 5 questions as we look at angiograms, and we'll be pretty much asking these questions every time. And hopefully, again, this provides a framework as you all kind of proceed to the cath lab. So these are the core views. I know that this is where we last left off in our first lecture. And I just wanted to kind of review the views again, as well as offer. So this is kind of a bird's eye view. I just wanted you to kind of see all of the views that we take for the left coronary and then for the right coronary. I myself am a visual learner. So after this slide, the remaining slides will actually put a visual diagram with each of these angles, just so that you have an idea of what does the left coronary look like with REO 20, caudal 20, or what does it look like with LEO 30, cranial 20. But I just wanted you all to have kind of a bird's eye view. So once we've engaged the left coronary, my approach is, and the way I've been trained is to take kind of 4 standard shots. I call it the 4 corners. So we engage the left coronary in LEO. Once we're successfully engaged, I move the camera over to REO 20, caudal 20. It is important to know that, these angles are not rigid. Everyone's anatomy is different. Everyone's hearts come in different sizes. Patients can be rotated, but roughly you're going REO 20 degrees, caudal 20 degrees. And we'll kind of discuss the importance of that angle. Once you've got REO caudal, you then keep it REO, you just move the camera to the cranial. So that's the only thing that changes. You're just moving your camera toward the head of the patient. And then we'll discuss that. That's kind of your LED shot. And then after you've gotten cranial, you then turn it to the left. You maintain cranial and just turn the camera over to the left. And again, that's another view of the LED. And then finally, after you've taken that shot, you then move it from cranial to caudal for the spider shot. And again, we're going to go over these angles several times today, but I just wanted to introduce it as we kind of take a step forward in our interpretation of angiography, that we're going to focus on these angles today. One just big pearl that I would share is that, with angiography, we're looking at a 3D structure in 2 dimensions. And so it's a great idea. And that's why a lot of these angles, you're going to look at the left circumflex in 2 views. You're going to look at the LED in 2 views. You just want to corroborate and make sure that, hey, and is what I'm seeing in one view the same in the other view, or is this perhaps just an eccentric kind of view, or an eccentric lesion? So that's just a common pearl that I would share, is that anything you do in the cath lab, it's always a good idea to take 2 views. So same thing with the right coronary, we engage in LAO. So oftentimes once you've engaged, you're pretty much set up for your shot. If you'd like to, you can put a little bit of cranial on it, and we'll go over that today, but it highlights the PDA, PLB bifurcation, which is very important for us to see. And then in terms of just getting that second view, oftentimes you'll see some people are confident that they've seen everything with that one view, but personally, I like to also take an REO shot. Just again, gives you a little bit more evidence, gives you another view of the RCA. And again, we will put a diagram to each of these angles so that you all have that kind of from a learning perspective. I think when I was first learning angiography, it was kind of confusing with all of these different angles, but I think the picture certainly will help. So I'd like to first focus on the left coronary. So like I mentioned, once we've engaged the left coronary, the first shot that we take is an areo-caudal shot. So that's what we're looking at here. And if you recall, I had mentioned areo 20, caudal 20. For this patient, they needed 40 degrees to get this view. So like I said, everyone's anatomy is different, so don't hold yourself to those angles, but this is the first shot that I like to start with. Now, as the first-year fellow in the lab, a lot can be happening. There oftentimes is a third-year fellow, interventional fellow attending. Multiple people have kind of hands-on equipment. And so you're trying to simultaneously do your role, whether that's hands on the catheter or hands on the contrast injection, while also interpreting. And so a pearl that I want you all to take away from this talk is that an important point with the areo-caudal shot is you're just looking at the left circumflex. So oftentimes I've had some attending say, yes, so here, looking at this areo-caudal shot, this is our left circumflex. It's splitting into OM1, splitting into OM2. This is your AV groove. And again, that was the left main, and that splits into the LED here. Yes, you can see the LED. Yes, you do see that there's some 30% stenosis, but really your focus, especially as things are moving quickly in the lab, you're just really mainly looking at the circumflex. It's a bit simplified, but I think of caudal is for circumflex and cranial is for LED. And so really, as you move forward, in the beginning, I would just say focus on the circ. Another important pearl that I want to kind of impart, and I think if you take nothing away from today's talk, I would take this pearl away, is how to distinguish the LED from the circumflex. Because oftentimes when you are approached with an angiogram, you're not going to have these labels here. And so I remember when I was, first learning angiography, I would sometimes get stuck. I'm like, am I looking at the circ? Am I looking at the LED? So the septals are your friend. So if you can identify the septal branches, then you know where your LED is. Okay. So let's say we didn't know what view this is, and we're just looking at this angiogram on a cold call. Okay, I see my septal branches, so I know that this is the LED coming here. This is the LED. This is, the circumflex, and I see my OM branches. If the circumflex is here, kind of in this downward position, this is an areo-caudal shot. So you kind of use that approach when you're looking at an angiogram. And so, here, I think we've identified the view, and what view is this? Whether radial or femoral, I think we need a little bit more X-ray to kind of tell, but it sure looks femoral because you kind of see that catheter outline there. Then we kind of named the vessels. And the next question here is, can you name the lesion? So I see a 30 to 40% stenosis here in the proximal circ, 30 to 40% in the prox LED. I don't really see anything in the left main. And as far as the diagnosis, I might say, mild non-obstructive coronary disease. So here's that diagram with the annotations, and I've just labeled kind of each of the vessels that we discussed, as well as kind of the stenoses. But again, the septal branches are your friend. And I know, the cardiovascular board exam is quite far away, but I think that is an important tool to use, when you're studying for boards or taking the boards, is where are my septals? Because once you identify the septals, you'll know where the LED is. Okay. So we'll kind of keep moving along here. So the next shot is the areocranial shot. So again, our camera was areocaudal, and we will then be moving the camera from caudal to cranial. And again, cranial is for LED, caudal is for circumflex. So let's kind of take that approach and again say we didn't know what view this is. Okay, where are my septal branches? I know I'm in the left coronary. This doesn't look like a right coronary. Okay, so here are my septals. It's a big septal there. And so I know, okay, this is my LED. This is my LED. That means that's my diagonal one. That's my diagonal two. Okay, if that's my LED, that means this is my circumflex coming here. So what I want to highlight, just like in the areocaudal, we said, just focus on the circumflex. I encourage you to, for areocranial, just focus on the LED. Yes, we can kind of see the circ here. Yes, it definitely looks diseased, but I'm not going to focus on that. I'm just going to focus on my LED here because this is really my LED shot. Okay, so again, in what view? This is our areocranial. Is it radial or femoral? I think we need a little bit more X-ray to be able to tell that. Can we name the vessels? We went through and did that. Can you name the lesions? So let's kind of identify the lesions. So this is definitely a diseased LED system. There's some prox LED disease there. I would call this about 60, 70% in the mid. Remember, it becomes mid LED once you go past your first diagonal. Then some more disease here, 60%. Then I would call that a 90% LED as you're getting into the terminal apical LED. And then in terms of our diagonal, this D1 looks very diffusely diseased. And then looking at this diagonal too, I would call that kind of a 80% long kind of tubular lesion. So here are some of those kind of, the lesion assessment. And of course, the diagnosis here is severe coronary disease. I think we'd need to see the rest, but this might be a case of multivessel disease and kind of conversation for interdisciplinary care with, cardiovascular surgery versus interventional, essentially. But this is our areocranial shot that's kind of highlighting the LED. So now from areocranial, we're just going to move the camera over to the left to get our eleocranial shot. And again, the eleocranial shot, cranial means good for LED. So again, here, let's apply that pearl, which is find the septals. So the septal branches here are right here. You see these large septals coming. So that tells me, okay, this is my LED. This is my diagonal. And if that's the LED diagonal, that means that's the circumflex. So again, we use the septals to identify the LED, and we're in the eleocranial shot. For radial or femoral, this time we can answer it. If you notice, you see this catheter coming beneath here. That means this is femoral. And this looks like a JL4 catheter. So this is definitely a femoral approach. And then in terms of naming the vessels, we went ahead and did that. And then in terms of naming some lesions, so here's the left main, kind of some mild disease here, maybe some, mild 20, 30% stenosis. Not seeing too much in the diagonal. Same thing here with the circumflex, maybe 20, 30% stenosis. And so I'd probably just call this kind of some mild non-obstructive disease. And so here are those labels. So again, just kind of repetition, I think, is important when kind of learning angiography. So again, the septals are your friend. It will help you identify the LED. And I think once you've kind of identified one vessel, the rest of it falls in place. I will take a moment to just comment on stenosis severity. I remember when I was learning angiography, I used to wonder, wow, how do my interventional fellow and attending know that it's 60, 70? It is subjective. So I want to encourage you all as you're kind of learning angiography that I kind of categorize it as mild, moderate, severe. I know that 70% is that cutoff that we kind of use for, does it need a stent or not? But I will kind of share that you will see throughout your training that what someone else thinks is 80, someone might think is 60. What someone thinks is 90, someone might think is 70. And what someone thinks is 50, someone might think is 70. So, don't feel like you have to get these numbers of 30%, 40%, but as long as you have an idea, this is mild, this is moderate, or hey, this is severe, I should probably, do a hemodynamic assessment or potentially fix this, then I think you're in a good spot. So finally, from cranial, we'll then move our camera to the caudal position. And so again, caudal is for the circumflex. And so this is our spider shot, aptly named because it looks like a spider. And again, I typically use LEO 30 to 40 and caudal 20 to 30. So they went all the way to 50 degrees and 30. So again, just having to change it depending on how you can get your best shot. But this is our left main, this is our circumflex, and this is our LED. So again, we'll use that principle. It's a little harder here, but these are kind of your septal branches. The takeaways that I want to share for the iliocaudal, it is your view for your circumflex, so that's important. But this is also a really good view for the left main, the ostium of the circ, and the ostium of the LAD. So when we're in that iliocaudal shot, that's what I want you to be focusing on. Am I looking at my circumflex? Am I looking at my left main? And am I looking at the ostia of both vessels? You'll find when we do left main interventions, we're often panning the camera into this angle because we want to see, is the stent hanging out into the aorta and how much is it doing so? So those are kind of the takeaways, and I've kind of highlighted that here on the right. And so we've identified the view. This is femoral. As you can see, the catheter is wrapping around the aorta there. And we've named our vessels. In terms of lesions, again, just some mild disease here, maybe 40, 50% here. And again, you always need to look at it in more than one view. So the diagnosis here would again be mild to moderate non-obstructive disease. So here's that annotation. So that's the left coronary. And now I just want to take a couple moments to focus on the right, and then we'll go ahead and dive into angiograms. So the right coronary, it's much simpler than the left. Again, you engage the right coronary in the LEO position. And so again, you see here, this operator has decided to put some cranial on it. And again, the main reason is you really want to be able to see this bifurcation of the PDA, PLB. So I think, with time, in practice, you'll see this is a right coronary. It looks very different from the left. And then in terms of, radial or femoral, you need a little bit more X-ray to be able to tell that apart. This is your prox RCA, mid RCA, distal RCA, PDA here coming on the bottom, PLB coming on top, and then really not much disease that I'm seeing. So kind of, mild disease if that. And so here's that annotation with the LAO cranial shot of the RCA. And again, you just want to highlight that split of the PDA and PLB. Because remember, the PDA is what determines dominance for right versus left. And we'll kind of discuss that in today's cases, how that is important kind of when making decisions about intervention. So after you take an LAO shot, we just need one more shot of the right. Let's bring the camera to the REO position. So this is your REO view. And I definitely did want to share this because it's a view we're not as maybe comfortable with, or one that we don't see as much, but this gives you another view of the RCA. And in this view, always with REO, PDA is coming off to the right and PLB is coming to the left, okay? And again, it's just another view, if you're looking at a lesion in the PDA or PLB, it kind of helps you see that a little better. It also helps you see the body of the RCA. So again, in what view? This is an REO view. We can't tell radial or femoral here. We've named our vessels. There is some disease here. As you can see, this contour is not as smooth. So definitely some mild disease. And then diagnosis is mild disease. And so here is that kind of annotation. I will say there is, definitely some small diffuse disease here. Definitely would not go after that because it's just so small and distal. But there is some diffuse disease there. So that is the areocranial shot. And again, we just like to take 2 shots of any vessel that we're looking at. Perfect. So that's the didactic piece. I think next we're going to go ahead and read some angiograms on cathab.org. So allow me one moment to pull up those angiograms. Okay, so with the course here, we've divided it into right and left coronary. So we're going to start with the right. I just want to confirm everyone can see my screen.
Yes, we can.
Perfect. So this is our first case. I'm just going to zoom in here. Again, just let me know if you can't see the screen, but use those 5 questions that we discussed to kind of approach this angiogram. So I'll play it a few times, but the questions are, in what view is this? Is it radial or femoral? Can you name the vessels? What are the lesions? And what is the diagnosis? So I'll play it a few times here. And feel free here to, post in the chat box your answers, and we'll take a look at them. Give me 1 second, just pulling up our chat box here. Well, I am not seeing our chat box. Oh, here it is. Perfect. So someone responded, iliocranial femoral approach, RCA, no significant lesion. So that's perfect. So we'll just kind of walk through this angiogram. I'll just kind of pull this up again here. So again, this is our LEO shot. We're looking at the RCA. We see that split into the PDA, PLB. And again, you know that it's femoral because you're seeing this catheter come up from the top here around the aorta. And then in terms of vessels, we've kind of identified PDA, PLB. And what I do, I'll pause it here. I want to highlight this could kind of be perceived as a lesion, but really I think it's just a kink in the vessel from the catheter itself. And so I don't think there's really any disease here. So I agree. I think this is a normal RCA. So we just come down here, and this formatting is similar to boards where you only click normal if everything's normal. It applies more to the left, but you'll see like if you think one of the vessels is normal, but the other is abnormal, then you do not click that. You only mark the disease vessel, but here it's all normal. So that would be the answer. And we'll just kind of pull up that diagram like we said. You know, I think that's a kink from the catheter, so I would not necessarily label that as disease. And this is just a big RV marginal branch. So I just wanted to do this case because I wanted you all to kind of be able to see what a normal RCA looks like. And so we will go ahead and move to the next case. I think case 8 is another good case. I've kind of handpicked cases today that I think are good didactic cases that you might see in your training. So here's a full screen. So you do see 2 angiograms here, one on the left and then one on the right. And I will give a hint that between these two, there has been an intervention. They've given 200 micrograms of nitroglycerin. So I'll let it play here. And again, I would just kind of approach this angiogram with those questions that we said. The view, the approach, vessels, lesions, diagnosis. Give it another 10 seconds here. Perfect. So pretty much what we're looking at here, I'm just going to pause it. Okay. So what we're looking at here is, again, with the RCA, you'll see most of our standard shots are LAO. The REO is kind of a distinct view. So again, it is LAO here. It is femoral because again, you're seeing that catheter come around. And then this is RCA splitting into PDA, PLB. And then in terms of the lesion, I think you would agree, you see kind of this is diffusely diseased here, but this is a severe lesion here. Now, the interventionalist gave 200 micrograms of nitroglycerin, and then you have this vessel. And if you look at this vessel, it's a smooth contour. So I would actually say the diagnosis here is coronary vasospasm, and it would be normal. And so we'll just go over to our answers here, and then we'll kind of talk about this one. But I think this is a case of a normal RCA that just has vasospasm. And for the board's purposes, there is an option for vasospasm, but for our introductory course, the focus is on angiography, just kind of interpretation for vessel severity. So again, this is normal here, and you see kind of resolution of the spasm. So I did want to take a second to comment on, the nitroglycerin. You'll find that your interventional fellows and attendings are often giving nitroglycerin kind of after they've taken a shot, after they've placed a stent. And it just kind of shows you and helps you understand that, vessels that are really clamped down or spasm, they really do truly improve with nitroglycerin. With this patient, we don't know what the history is, whether this patient was using, using drugs like cocaine that, will cause vasospasm, or a female patient that might be predisposed to vasospasm. But it just underscores the importance of that nitroglycerin and really, making sure that you rule out vasospasm, because I think someone would have gone ahead and stented it if they had not kind of checked for vasospasm. So it really is about that clinical picture. So just always kind of keep that in your differential diagnosis. Okay. So we'll go ahead and do another case. curious everyone's thoughts on this. So this is the case, and this is actually a still frame here. So I'll give everyone a second here to kind of put together their thoughts and kind of approach it kind of with that same algorithm that we've used. Okay, perfect. So some people have kind of picked up on it here that this is an eleocranial shot. Again, we don't know for radiofemoral. I think one piece of information, again, prox RCA, mid RCA, PDA, PLB, as far as naming the vessels. Then in terms of lesion assessment, just want to comment here, there is that 80 to 90% PDA. I noticed somebody caught on to that, which is awesome. So definitely there, but the key point here is this dissection here, or severe disease in the proximate RCA. And again, that is the diagnosis here. This is a RCA dissection. And so we'll go ahead and mark our answer here, that severe disease, and that way we can pull up kind of our explanation. But I just want to take a moment to kind of discuss the RCA dissection here. So, I remember when I was a first-year fellow, I often heard people talk about dissections, and I didn't really quite know what that looked like. And this is why I've included this picture in the course, because I want everyone to have an idea of kind of what that looks like. This is a very gross example of a dissection. So you see this clear lucency here, this tear in the proximal kind of mid-segment of the RCA. And so whenever you see that dissection, as the arrows are indicating here, it is important to kind of have a broad differential diagnosis. In this case, I think if you look at the catheter and the catheter position, it doesn't really look coaxial. And that's why in that first lecture, we really highlighted the importance, you want your catheter coaxial, you want to look at your waveform. If everything looks good, then you inject. If your catheter is buried in the floor or buried in the roof, and you don't have a great waveform and you just inject contrast, that turbulence can cause a tear in the intima. And you can really get yourself into big trouble, especially here. I guess we can't call this a normal RCA because this is disease, but oftentimes if the catheter is not sitting correctly in a normal RCA, you can unfortunately cause a complication in this patient. So in this case, I think this is catheter induced. That said, I do want to cover some of the other complications of dissection, other differentials of dissection. So one is with the guide wire. And I know that in the beginning, many of you, will not will not get the opportunity to wire, but maybe with time, your attendings may kind of let you get your hands on that. And so as we advance the wire, sometimes if the wire is not advancing smoothly through the vessel, the wire is kind of poking into the intima. And that's what we worry about as operators, that, are we causing a dissection, if it's not going smoothly? So that's definitely something to think about. Another cause of dissection, believe it or not, is just the ballooning itself. These are really diseased vessels, and these are friable arteries. And, when the balloon goes up, sometimes it can cause a tear in the vessel. And that is not routine, but it's not unexpected. And so, when we see that, we just quickly want to tack that up with the stent. But I just wanted to make sure that you all understood that, dissections don't always occur and appear like this. Sometimes when you've inflated the balloon and then you take your balloon down, you might see a little bit of haziness kind of on the edge, and that is a dissection. Now, the one I do want to take a moment to also comment on SCAD, because that is a diagnosis you all will come across, spontaneous coronary artery dissection. So that is also a dissection, but it's a little different. So in that case, these are often cases of young women who are pregnant, maybe patients with Marfan's or Ehlers-Danlos who have connective tissue diseases, kind of friable diseases. The idea really is that the coronaries are healthy, but there's a tear in the vessel that occurred spontaneously. In cases of SCAD, we do not like to stent. So all of these cases, like this one, from the catheter or from the balloon or from the wire, you're going to want to stent because that's going to be flow limiting, cause an issue. In a case of SCAD, you do not want to stent. The thought process being this is not coronary mediated, that this should heal with time. Now, you may come across cases of SCAD that are STEMI or flow limiting, or things that you aren't able to medically manage. And sometimes your hands can be tied and you do have to stent. But overwhelmingly with SCAD, we try not to stent. So I just thought this was a good case for us to kind of discuss, and that's kind of what this description goes over, just differential diagnosis of dissection and spontaneous coronary artery dissection. So we'll go ahead and move on to the next case. Just a couple more for the right, and then we'll kind of focus on the left coronary. Perfect. This is a good one. This is a view we've not seen in the cases we've done so far. But again, this is just kind of take that standard approach. What view is this? Is it radial or femoral? What are the vessels? What are the lesions? And what is the diagnosis? I'll play it a few times. There's a little bit of a subtlety here. I want to see if everyone picks up on it. Feel free to comment in the chat, or we can go through this one together. So pretty much, I'll just play here so that we get, so first, let's go through the main points, and then we'll go through the subtlety. So this is a view of the RCA. This is a view that, we've seen 3 examples now. So this is that ARIO view that we did in the didactic portion. So again, I just want you all to be able to see that, we do use that view. So this is ARIO. Again, unfortunately, we don't know radiofemoral. They haven't provided enough of X-ray for us to see that. But in terms of vessel, prox, mid, distal RCA, then PDA, and then PLB kind of on this side. And then in terms of lesions, this looks pretty good to me. I don't see any lesions. Of course, I do see this guide wire that's there, so we haven't really been seeing that. And then what is the diagnosis? So here, there's no stenosis, so you could say normal, but I will say that, this is not a normal RCA, because if you pay closely attention here to the X-ray, you see this contour, almost like a train track or a railroad track. So that is a stent. And, as you get comfortable, you'll see that basically what they did here is they probably fixed something in the RCA. They left the wire in. We're just kind of taking a final shot, just making sure everything looked good. So that's why we see the guide wire. Kind of tips you off that maybe an intervention was done. But yes, there is definitely this long kind of prox to mid RCA stent. And so, again, here we would call it normal, but when you're kind of dictating your report, I would say, this is a dominant RCA bifurcating into the PDA, PLB. The RCA has a long stent, which is patent and has no disease. And so that's kind of what is highlighted here with these arrows. So this is the guide wire, and this is the RCA stent. So just something wanted to kind of, have you train your eyes on, and we're going to discuss a case of calcium. Sometimes it can be tough to distinguish, is this calcium or is this a stent? In this case, it's very clear that it's a stent, and of course the guide wire gives it away a little bit too. But these will be things that you will want to kind of train your eyes toward. And sometimes the patient can tell you they have a stent, and so it's not a surprise when you're doing the procedure. But oftentimes patients don't know their history, and when you're doing the procedure, you might see a stent and say, "Hey, they actually did have a stent." So that's kind of why I included this case to kind of just point out what a stent looks like on X-ray. Okay, keep moving along here. Wanted to point out this case here. Not a lot to see here, but a lot to learn. So this is our next case. And I'll let it play for a couple seconds here. Have it play one more time. So again, the big question is, what is the diagnosis here? What do we think is going on? But we, of course, will answer all those questions that we discussed. So here, I just want to point out what's going on. Let's go ahead and pause it. The first thing I want to point out, I'm just going to back it up here, is I want you to see how deep this catheter is engaged. So personally, I mean, this is a potentially acute situation, but I would just be very cautious of how deeply that catheter is engaged, okay? And again, this is looking like our LAO shot, and we obviously don't have a lot of coronary, but it looks like that is the kind of overall projection of it. Can't tell radial or femoral. We don't really have a lot of vessel to identify, but I think you can appreciate there's 100% occlusion here in the RCA. And then the question is, what is the diagnosis? So this is, I think, a great case that we can go ahead and discuss here. So I would code total occlusion. And the approach I kind of would like to encourage all of you to do with this is when you're approached with a total occlusion, the next question you want to ask yourself is this acute or chronic? So we've taken the shot of the right, and that's what we see. So again, the RCA is 100% occluded, but this is where it's important to know what is the clinical scenario here. So if this patient is coming in with inferior ST elevation, tombstoning elevation, chest pain, this is a STEMI. This is an inferior RCA STEMI. On the other hand, if this is a patient you saw in the clinic, you notice some Q waves on EKG in the inferior leads, they're still having some chest pain. So you decide to take them to the cath lab and they're very stable. This is probably a chronic occlusion. So I think the important point here is that you want to put the occlusion in the context of the clinical scenario. And so that's where the picture of the left coronary would be very helpful. If the left coronary is having collaterals to the right, that tells you, okay, this is chronic. If there are no collaterals, and of course, if your patient is really sick, that tells you, hey, this is acute. We need to get this open as quickly as possible within that kind of 90-minute door to balloon time. So I remember, I didn't really have a great concept of what a thrombotic occlusion looked like. And so that's why I included this here kind of for when I started. So again, I would just approach this as this is 100% occlusion, and you want to figure out, is it acute or chronic? And that would be based on clinical scenario, as well as kind of what does my left coronary look like? So that is this case in a nutshell. And then we've got one more case of the right, and then we'll move over to the left. I hope this is kind of helpful and kind of educational so that when you guys are in the lab, a lot of times you'll be able to recall that you've seen this case before or something like it. So this is a quick one. This is another case of an RCA. I'll let it play a little bit. Let it play one more time here. I think we have some answers in the chat here. Okay, so basically what we're looking at here is this is a non-dominant RCA. And I just wanted to include one example of that so that you all could see that. I've paused it here. So again, this is, view kind of looks like it's LAO, again, because you're kind of seeing it in that kind of C kind of formation. We can't tell radial or femoral. I don't see anything on the spine, so this is probably radial. With femoral, we're always seeing it overlay, the catheter overlay the spine. In terms of identifying the vessel, this is the RCA. You don't really see anything fill the PDA PLB, which kind of hints that this is non-dominant. And so that would kind of be my diagnosis here, that you see this is kind of a non-dominant RCA. All the RCAs we looked at previously, they were kind of large, beefy, of substance. This is kind of a small, piddly little RCA, kind of tells you it's not dominant, and then you don't see it filling the PDA territory. So again, it would be important to see what the left coronary looks like. I'm expecting a very large posterolateral branch from the left circumflex. So it's always good to kind of have those thoughts as you're kind of performing angiography. And the only other comment I'll make about dominance is that it really helps you decide, interventional is not as simple as like 70% lesion, let's fix it. You really want to see how much territory is it supplying? Is it going to be meaningful benefit to the patient? So if you saw a lesion here, honestly, I would leave it alone. It's a non-dominant RCA. It's small, probably be getting myself into more trouble and really not helping my patient at all. So here, this is a normal RCA, so we can kind of mark this as normal. See that it's kind of small caliber, but this is what a non-dominant RCA looks like. So those are the cases of the right that I want to discuss. Of course, there are many more cases in there that would kind of be didactic, but those were the ones that I kind of I thought they had some good teaching points to highlight. So with the left, I just want to kind of highlight a few cases that I think would be interesting and good for us to go over. So this is the first case of the left coronary. So I will let it play here. And again, with the left, it gets a little more interesting. So we'll kind of see what you all think about this. And again, I think by now you all kind of have that framework. So we'll apply kind of our framework here. So what I'll do is I'm just going to pause this here. Okay. So, okay. So again, that first question we said when we're looking at a coronary angiogram is what view is it? So it's a bit hard with pausing it on YouTube, but these are the septal branches here. And so I know that this is my LED on the right. This is my LED. This is my circumflex. This is my OM1. So if my circumflex is coming on the bottom, this is an ariocaudal shot. Next, is it radial or femoral? This looks like radial. Again, we don't quite see the spine, but based on the way it's looking, it looks like it's radial. Again, as long as you see the spine, and if there's a catheter, that's femoral. If there's no catheter, it's radial. So I think this is radial. Can you name the vessels? We just kind of went through and named everything. Remember, the ariocaudal, we're kind of focusing on our circumflex here. And again, I don't really see, any stenosis here. This is my left main. It looks good. LED, from what I can tell, looks good. So, I think this is a normal left coronary. So again, here's where if we had identified something in the LED, but the left circumflex was normal, we would click for the LED, and you'll see as we go through, but this looks like a normal left coronary system to me. There is one subtlety that I want to share with you all. So I just want to kind of share. So this is kind of the annotation, and I'm going to play it again, but there was actually a little bit of myocardial bridging in that left coronary system. So see if you can kind of pick up on that. And again, we would take a look at it in the cranial view, but since it is there, I just want to point it out. If you notice right around here in the LED diagonal, with bridging, right, it's kind of constricting and then opening in that systole diastole. So it's not staying constant. So just a little bit of myocardial bridging, just an interesting finding that I thought I'd kind of include here so that you all could see that, because sometimes that can be hard to see when you're in the lab. Okay, moving on. We'll move on to our next case here. Case 11. Okay. This is a good case. This is kind of full of different findings, so I'll give you all a second with this one. I'm going to move this out of the way. I don't know if you all can see this or not, but play it again a few times here. Play it one more time, and feel free to put your answers in the chat. I think this one has a lot of great discussion points. We'll take a look at what everyone's thinking. So in this case here, basically, again, we're going to kind of apply those principles. So we want to identify our septals, because we said that would help us figure out kind of which one's the LAD and what view we're looking at. So here are our septal branches. So I know that this is my LAD here. And if this is the LAD and it's in the center, this is an areocranial shot. This is my circumflex system. So that's coming on the top here. And so what I kind of identify, first I look at okay, so next we've identified areocranial. This is a radial shot. I'm looking at my spine here. I don't see the catheter really coming across the spine. So this is radial engagement. And then we've named our vessels. So next let's focus on the lesions. So to me, this left main looks tight. I'd call it a 50% left main lesion here. I'll play it again here. There is a 90% kind of long tubular stenosis here in that prox LAD. The left circumflex, this is the areocranial shot. This is not the view to focus on the circ, but it looks like it has some disease, but the LED, of course, captures your attention. And then the kind of subtle finding here is that you see these collaterals from the septal going to the RCA, and I'll play it again and we'll look at the still frames. But actually, based on this shot, the RCA is 100% occluded and it's being filled by collaterals from the LED. So I'm going to play it and then we'll take a look at the answer description. If you follow my cursor here, do you all see that RCA kind of lighting up here at the end? So that I'll play it again. That tells you that the RCA is 100% occluded and it's getting collaterals from the septals. See it lighting up again there. It's kind of heavy collateral formation. And you'll be able to see it in some of these still shots here. So again, we said we thought the left main was 50%. We thought the LED was severe disease. We thought the RCA is totally occluded, getting collaterals from the septals. And I think the circ we kind of couldn't quite see. We said maybe some mild disease there. So we'll kind of take a look here. So we've kind of gone through these pieces, identifying the septals, the 90% stenosis. And then this is kind of one of the main points that I wanted to bring up is the septals. You see this distal RCA is opacifying. You get another nice shot of it here. This is the RCA opacifying from the LED. So this is a bit of a complex angiogram, but our patients have really bad coronary disease, and this is definitely something you will come across within even probably 1 week of the cath lab. So I thought that this was a good angiogram to kind of go through. Okay, so we can kind of move on to the next case in the left coronary. And feel free if questions do arise, feel free to interject as well. Happy to try to answer questions along the way. So this is the next case. This is also, I think, a really great kind of teaching point here. So I'll let it play a few times. And again, you all have that framework that we're using to kind of interpret these. I'll let it play a few times. Okay. So feel free to kind of put some answers in the chat if anybody has any thoughts kind of on these. Take a look here. Perfect. Someone kind of said ariocaudal, femoral approach, 90% occlusion of the circumflex. So perfect. So, a couple things that I want to point out. So first, we'll go in our kind of framework. You see the septals are coming off to the right here. It's kind of hard on this paused view, but you're seeing the septals are to the right, so the LEDs to the right, means the circumflex is to the left. So this is our circumflex, and you see the panning with the catheter over the spine. So this is definitely a femoral approach. And we'll just pause it here. So next we come to the vessels. This is our circumflex. Again, this is the LED. And then you see this kind of 90% lesion here. See this 99% lesion here in the OM1. And you see this lesion here in the ostium of the LED. So this is a bit of an advanced angiogram, and I do want to kind of take some time on it. So as we're looking at it, what I want to point out, and as you're kind of looking at angiograms in the lab, notice this haziness here. You see there's like a filling defect here in the LED, filling defect here in the circ. So I would argue, that could be thrombus, that could be calcium. And some of that, again, is based on the patient's presentation. But some of that, too, is just looking at the angiogram. And if you look at this one, look at it before, look at this kind of densities here. It's almost as if you can see the outline of the LED in the circ. And we kind of saw that with the stents, but these are not stents. So this is calcium. So I would argue that these are heavily calcified segments. And so this is a very tough lesion. So it almost goes beyond just severe disease. And so as you're kind of talking about angiograms in the lab, I do think that these are kind of important to point out. And so I would say that there's a like 99%. I'm just going to play it now that you've seen those densities. It's a 99% calcified osteal LED lesion, 90% calcified left circ lesion, 99% calcified osteal OM1 lesion. So very severe disease. So we can go ahead and enter that here. Our LED was severe. We said the circumflex was severe. The left main, maybe some mild, moderate disease there. So again, you see that disease in the LAD, in the left circumflex, and of course there is that severe LAD lesion. But one of the main takeaways is highlighted by this diagram, seeing these densities, and that's consistent with calcium. I do want to take just one moment to kind of comment on calcium, and this is a good shot where we can take a look at that. With calcium, it's important sometimes that you do calcium modification techniques, and that's why I wanted to share them here before you come across them in the lab. We have kind of a couple techniques. The two notable ones are shockwave lithotripsy, and the other one is rotational atherectomy. So the idea is, if there's calcium here and you put in a stent, the stent's not going to expand against the coronary if this calcium is hard as a rock. And then your stent is deployed and it's malformed and malpositioned, and it's just not it's not great for the patient. And so what you want to do is you want to modify the calcium. So one option we have is shockwave lithotripsy. If you think back to medical school, with kidney stones, urologists used to use this to basically kind of shock the stones to kind of dissipate them or get rid of them. And so it's the same idea. We take a balloon and it delivers shock waves to this calcium and kind of breaks that calcium up so that that calcium is clean and our stent can deploy, easily. The other option is rotational atherectomy. It's almost as if we take like a burr or a vacuum and we just vacuum that calcium so that it's all clean, and then place a stent. But it's very involved and it can be quite risky. And I've had coronaries perforate using that. So, shockwave is typically safer, but a lot of times the balloon is bulky and won't pass. So this is, again, a little bit more on the interventional side, but I wanted to just share that's why it's really important to identify, is it calcium or is it not? Because it really will change your approach to how you intervene. So I included this here. The main teaching point was that this is what calcium looks like in angiography. Okay, do a couple more cases here. So case 33. This is a good didactic case. So this is a still frame here. And again, what view, what radial or femoral, can you name the vessels? What is the lesion? And what is the diagnosis here? So in this case, again, we see our septals. So this is the areocranial. See the LED, center of the screen. We don't see the circumflex. For radial or femoral, this looks like femoral, just based on the catheter positioning. And again, you see your diagonals coming across. This is a severe LAD lesion. And the reason I included this is what thrombus looks like in the LAD. This is probably a STEMI. It could also be an NSTEMI, but most likely this is a STEMI, just looking at this clot burden here. I included this because, again, when I had started the cath lab, it's not something you come across all the time. And so I just want your eyes to have seen it once before. Maybe you all have already come across cases of thrombus, but this is basically what thrombus looks like. And remember, thrombus can be, coronary embolization, but can also be from AFib, can also be from clot sitting in the left ventricle. But basically, this haziness, anytime you see haziness or a filling defect in the coronary, something's not right. You're thinking about calcium, you're thinking about clot, and this is what clot looks like. So again, I would just kind of check severe disease for LAD, and the diagram here just kind of pulls up this kind of hazy filling defect that you see. So just wanted you all to kind of see that case, so that you have an idea of what that looks like. Okay, the next case we'll do is case 35. I'll just play this a few times. This is a little different than things we've looked at on the left coronary system. Let it play one more time. So our algorithm won't exactly work for this one because it's a little different, but just want to see if anybody took a stab at this one. Perfect. So limit LED. So you guys are good. You're spot on. So I'm just gonna kind of enlarge this, but yes, this is what a Lima to LED graft looks like. So you all will be involved with bypass cases. Again, I want you to pick up on these sternotomy wires, kind of tells you that this patient has had their chest cracked open, has had open heart surgery. And then we'll take a look here at the bypass piece. I'll just back up here. It's a little hard to tell here. We can take a look at the diagrams, but basically this is a normal graft to the LED, and the LED is normal. So again, it's normal because both segments are normal here. And I just want you to see the anastomosis. I'll just pull up my diagram here. So perfect. So you see the Lima graft coming and anastomosing to the LED. And this is the LED beyond the Lima. So this is the first case that we're doing together that's with a graft. So I just want to take a moment to kind of comment on that. Again, we discussed the sternotomy wires. So anytime you're looking at a graft, you're looking at the graft itself. Again, the Lima to LED looks good here. As someone in the chat aptly identified, this is a femoral approach. Believe it or not, we can access the Lima from a left radial, but most commonly people use right femoral. And so they've engaged the Lima graft here and there's no disease. But when you're looking at a graft, do not just comment on the graft itself. You also want to look at the LED or the vessel beyond the graft. So if you're looking at a vein graft to the right, you want to look at the RCA, distal to it and proximal to it for that matter. But distal is especially important because if we had seen any disease here, then, the Lima LED is helpful for the proximal part. But if there's disease distal to the graft, then the graft is not enough. And then we may need to be fixing this. So just be sure that anytime you're looking at a graft, don't just look at the graft itself, look at the vessel that it's supplying as well. So I thought this was a good case to include just so that you can see kind of what does a Lima to LED graft look like. I know I hadn't seen what it looked like before I started fellowship. So this is just an example of that graft. And so that's kind of an example of that case. And then I've got two more cases that I want to kind of go over. And then, of course, happy to take any questions at the end. But two more cases that I think will just be helpful for you all as you kind of approach. Now, these are not coronary, which is, I think, a giveaway, but I think just important for us to kind of go over. So this is an LV gram, as you all probably know. And so just curious kind of what your thoughts are. I'll let it play a few times. So again, our approach doesn't really work here because we're not really looking at a coronary. Just want to take a second, see if anybody in the chat has some thoughts about what we're looking at. Okay. So someone mentioned Takotsubo, and we can discuss that. So basically, this is a pigtail catheter. So it's not a coronary catheter, okay? And from kind of the way I see it, it to me looks like this is a normal LV gram. So the function is preserved. The wall motion is kind of coming in. With Takotsubo, you kind of see anterior hypokinesis and basal hyperkinesis. I don't think I appreciate that here as much. I think the walls all kind of look like they're coming in pretty well. It's kind of pumping well kind of all around. And so again, this description here kind of doesn't apply because it's more for coronaries, but I've just included it kind of for your education. And so I just want to pull up the diagram that highlights the walls, but I just wanted you all to kind of see, the pigtail catheter in the ventricle. And then again, with the LV gram, you have your LV cavity. This is the aortic valve, aorta. And again, this is your anterior wall. This is your apex. This is your inferior wall. Now, some people do LV grams routinely. I think echocardiography is obviously a great tool that we have. I think LV grams are good in some cases, if the echo is foreshortened and we don't have a great view, maybe of the apex of the LV, then it's a good use of it. But again, this is something that you will see quite commonly, so I wanted to kind of include that so you get a sense. It is another tool that we have to discuss ejection fraction assessment and wall motion. So that is that case. And then just have one more that I wanted you all to see. And again, it's another pigtail case. I want to see what everybody thinks about this one. So here, I'll give you a hint. The pigtail catheter, as I play it again, sitting on the aortic valve. It's not in the ventricle. And so this is what we call an aortogram. So it's sitting on the It's in the aorta on the aortic valve. Just take a second here and see what everyone's thinking. So this is a little more challenging, and if you haven't seen it, it just kind of takes one case to kind of have an idea. But basically, when the catheter is sitting in the LV, you can pull it back to the aorta. That's how you get that pullback pressure. And depending on the case, we don't do this every time. You can do an aortogram. Now, the reason for this, and I just wanted to pause it here, this is a really good test for us for two things. One, you could have pulled it up here and you can get a sense of how dilated is the aorta. It's just like another assessment of aortic aneurysm, essentially. But you'll commonly see that we use it to assess aortic regurgitation. So if this catheter is sitting here, the blood is going forward, so you should not see this regurgitation. So as I play it, you're going to see there's severe aortic regurgitation. All of this contrast reflux back into the ventricle to the point that it's lighting up the ventricle. That is severe AI. So again, you'll see sometimes you get cases in the cath lab because people just want an additional tool to quantify the AI, and that's why we're doing this aortogram to kind of see how much aortic regurgitation is there. I will just point out one more thing, as you all may notice, with these large injections, we're seeing the coronaries light up. So sometimes when we can't find that right coronary or that left coronary, we might do an aortogram shot, and that's basically so that we can figure out, hey, where does the ostium of the right take off or where does the left take off? So I just wanted you all to see that this is another use of that aortogram shot, is to be able to kind of identify the coronaries. I'll let it play one more time. So you see those coronaries light up. And honestly, we do it for grafts cases too. If we can't see where the graft is, we pull it up a little bit more, and it helps us figure out where the grafts are. So again, I'll just kind of click normal. These descriptions don't apply to the LV or aortogram cases, but it basically shows you that same thing, that extensive contrast reflux. And again, it's just highlighting